the Non-Communicable Disease Program at the Pan American Health Organization in Washington, D.C., and it's with great excitement and enthusiasm that I welcome you all to this regional launch of the Global Cervical Cancer Elimination Strategy. I've been working for many, many years to improve public health programs for cervical cancer, so I'm so thrilled to see this global momentum to really accelerate efforts around eliminating this devastating disease that affects thousands of women worldwide. To commemorate this momentous occasion, we have several representatives from governments and civil society partners who will be speaking with us today about their unequivocal support to reach the global targets for cervical cancer elimination. And to help kick us off in our session today, Dr. Jarvis Barbosa, PAHO's Assistant Deputy Director, will provide welcome remarks in a pre-recorded message as he had a conflict in his agenda today. So let us welcome Dr. Barbosa in his message.
Good morning. My name is Jarbas Barbosa. I am the Assistant Director of the Pan American Health Organization. And I'm honored to join the WHO Director General, Dr. Tedros, in the call for global action to eliminate cervical cancer, a disease that affects thousands of our mothers, sisters, and daughters. This regional launch event is being held with representatives from ministries of health and civil society, partners, to demonstrate our full commitment and support to this ambitious endeavor to eliminate a highly preventable disease, cervical cancer. Cancer is the second leading cause of death in the Americas, and cervical cancer is among the leading types of cancer in women in our region. More than 83,000 women are diagnosed with cervical cancer, and more than 35,000 die each year from this disease. Like most diseases, cervical cancer exacerbates existing inequalities. This means women who are poor, who have limited access to health care services, and those living with HIV are particularly at risk of developing cervical cancer. Unlike other cancers, we have an effective vaccine to prevent cervical cancer. We also have tests to detect precancerous lesions and effective treatment to prevent these lesions from developing into cancer. That is why I am pleased to launch the strategy to eliminate cervical cancer in the Americas, which comes on the heels of the PAHO Direct Cancer adoption of the Regional Plan of Action for Cervical Cancer Prevention and Control in 2018. With this new elimination strategy, we are asking countries to reach 3 new targets for vaccination, screening, and treatment. First, we must ensure that at least 90% of girls under the age of 15 years receive the HPV vaccine that prevents cervical cancer. Second, we need at least 70% of women between the ages of 35 and 45 years to be tested for HPV and screened for cervical cancer. And finally, we must ensure that at least 90% of women diagnosed with cervical cancer receive prompt treatment, including palliative and supportive care when they need. While these targets are ambitious, especially in light of the new challenges posed by the COVID-19 pandemic, we remain optimistic that we can work together towards these targets. PAHO is committed to supporting our member states to reach these new targets, and we are counting on your full engagement. Today's generation of women can be the last generation to live with the threat of cervical cancer. I hope you join us in making this vision become a reality. By redoubling our efforts, we can eliminate cervical cancer once and for all. Thank you.
Great, thank you. And that was Dr. Jarvis Barbosa bringing us welcome remarks for this regional launch of the Global Cervical Cancer Elimination Initiative. And to bring the voices of women who've been affected by cervical cancer, we'd like to now show you a short video of women from the region.
El cáncer es una enfermedad que se lo come a uno en tan poco tiempo.
Cancer is a disease that consumes people in such a short period of time. In my case, I lost a friend
el cáncer y
to cancer,
fue bien triste el
and it was very sad to see her and to see the pain that
con ese tipo de
these types of diseases cause. Then I went in with the doctor and she told me that I was HPV positive. At first I felt something very strong. Now I'm not someone given to crying, and so I said, my goodness, the first thing you do is trust in God. And then I told the doctor, tell me if I'm going to die or not. And she said, it has not yet become cancer. It's something that can be eliminated, she told me, that can be treated. There's a treatment that can be administered. I forget the name, HPV. And I said, yes, well, give me the publication so I can see if I agree with the treatment program. And I said that I was. For my life and for my daughters.
Everything in my power to ensure that she has a bright future. I said yes to the HPV vaccine.
Todas las mujeres debemos de estar al pendiente de nuestra salud.
We all have to care for our health, given the fact that we are women, so that we can live and enjoy our children, our families, and everything that comes along with that.
And I think all the girls out there should take it to prevent cervical cancer. It's time to end cervical cancer.
That was excellent. And it certainly is time to end cervical cancer. So the threshold for cervical cancer elimination has been established as 4 cases per 100,000 women. And this may seem extremely ambitious, especially in our region where there are still many countries and pockets within countries where incidence rates are well over 20 per 100,000. But this elimination strategy, with its 90, 70, 90 targets, have been created based on data and evidence showing that it is feasible. And to present these data, I invite our next speaker, Dr. Jane Kim, who's professor of health decision science at Harvard University and who is part of the WHO consortia to model these data to present on the results. Over to you, Jane.
Thank you very much. Let me go ahead and share my slides. Did that work?
Yes.
Excellent. Okay, great. Well, thank you so much for the invitation to be here. I'm so pleased to present our work on estimating the global elimination of cervical cancer using mathematical models. I'd like to acknowledge that this has been a long and ongoing effort in collaboration with the World Health Organization and with modeling groups from different institutions, including the University of Laval in Quebec, Canada, and Cancer Council New South Wales in Sydney, Australia, along with my team at Harvard University. So there are several key questions to be addressed in order to make this call to action to eliminate cervical cancer a reality. The first is, what is the right cervical cancer threshold to achieve elimination as a public health problem? And you've already heard from Silvana that a threshold of 4 per 100,000 women for cases has been established, and I will be presenting our results in that context. The second question, what combination of screening and vaccination strategies can lead to elimination? When can elimination be reached for different strategies and in different countries? And what is the most efficient or cost-effective strategy to reach elimination? Can we reach elimination in a way that provides good value for money? Because of the limited time, I won't be able to spend too much time telling you about our methodology, but just to summarize the strategies and the approach, we used 3 independent mathematical models. This is to provide more reassurance in our results. So rather than relying on just a single model, we utilized 3 to project cervical cancer incidence and cases over time for 78 low and lower middle income countries under 3 main screening and or vaccination scenarios. So scenario 1 involved high coverage of adolescent girls only vaccination. So 90% coverage of 9-year-old girls in a routine program. and a 1-year catch-up program of 10 to 14-year-old girls. And this scenario 1 assumes no change to the current screening coverage and practice. Scenario 2 involves the same high vaccination coverage, but in addition, we assume a one-time screening at age 35 years old, assuming that screening coverage can be ramped up over time and reach 90% screening coverage by year 2045. Scenario 3 involves, again, the same high vaccination coverage of girls only, and this time with 2 lifetime screens at ages 35 and 45 years old, also assuming that we can reach a high level of coverage of 90% by 2045. All of these scenarios assume that vaccination had 100% lifelong protection against 7 oncogenic HPV types that are included in the broad spectrum HPV vaccine. Screening was assumed to be HPV-based and involved 100% treatment efficacy, and we assume 10% loss to follow-up. So just to jump to our results, I'm going to show you how age-standardized cancer incidence rates per 100,000 women, which is along the y-axis here, changes over the next 100 years along the x-axis for each of the models. And this is just to demonstrate our model consistency for the no further change scenario. We have low-income countries on the left and the lower middle-income countries on the right. And you can see here that across the 3 different models that under a scenario of no further change, so this is no ramp up of vaccination or screening, that our models provided quite consistent baseline projections. And then in scenario 1, which again involves vaccination only, across the 3 models, we had also very consistent trends and results across the 3 models. So what we're going to show in the next graph is basically an average across the 3 models, just for simplicity. So now I'll show you the differential in cancer incidence across the 3 different scenarios. This blue line here is indicating our threshold of 4 per 100,000. And so in the low-income countries, that has a relatively high starting burden of roughly 40 per 100,000 women, we see that cervical cancer incidence is unlikely to reach the elimination threshold when we only assume vaccination only. Okay, so this kind of stapled line here is representing our scenario 1, and we see that it never crosses the threshold of 4 per 100,000. However, with once in a lifetime screening, which is shown by this middle dotted line, we do see that we cross this 4 per 100,000 threshold at roughly year 2089. Okay. And then that occurs actually, the crossing the threshold occurs 6 years earlier when we assume that vaccination is offered alongside 2 times per lifetime screening. So that's the solid line here. In total, this translates to between 3.5 and 4.3 million cases averted compared to no prevention scale up. And this is, again, aggregated over the low income countries. And this is by year 2120, so within 100 years. On the right-hand side, for the lower middle income countries, we see that we have a starting prevalence that is far lower, almost half, roughly 20 per 100,000 women. And elimination is predicted to occur in all 3 scenarios and earlier. So in this case, with the vaccination and the 2 lifetime screens, we see it the threshold crossing at around year 2069. And then in total, in aggregate, in the lower middle income countries, there are roughly 11.5 to 14.2 million cases that could be averted, depending on which scale-up strategy we're talking about. Now, another way to look at this is looking at country-level results. And we can do this by referring to the world map where we can see when and if different countries reach elimination over time for the different strategies. The dark blue region indicates a low burden, and this is at our threshold of 4 cases per 100,000 women. The lighter blue is indicating a slightly higher threshold that we had been also considering of 10 per 100,000 women. And then the red indicates a higher burden, greater than 10 per 100,000, with the darker shading indicating higher burden. So as the map changes over time, as I scroll through our slides, you can see that how these countries are changing with each of the strategies. You can also keep your eye on the left-hand side here and see how the proportion of countries eliminate by the different income groups and by region. Okay. So starting with our first scenario that includes vaccination only, this is the starting distribution, the current distribution of cervical cancer incidence in the 78 low and lower middle income countries. And over time, we don't see any changes. This is year 2030 now. We start seeing some changes in year 2045. In 2060, we start seeing some countries in Asia and Africa reaching 10 per 100,000. By 2075, more countries in Africa and the countries in the PAHO region are below 10 per 100,000. And then we see this trend continuing through 2120. And as you can see, there are several countries, even over 100 years that don't meet the elimination threshold of 4 per 100,000 with only vaccination. In terms of timeline, in regions that did achieve elimination, we see that occurring around year 2080 as the earliest, and then 2063 if we're adopting the 10 per 100,000 threshold. So now for scenario 2, again, this is the current year 2020 current cervical cancer incidence in the 78 countries. When we add to vaccination the once in a lifetime cervical cancer screening, we're going to start seeing countries crossing into the blue zone a little bit earlier. So here's 2045. In 2060, we see PAHO countries starting to fall under the 10 per 100,000 threshold. Here's 2075, 2080, 90, 2015, and 2120. So again, in 100 years. By the end of the century, we have most of the countries reaching elimination. We see that occurring between years 2072 to 2080 and earlier with the 10 per 100,000 threshold. But there are some countries in Africa and sub-Saharan Africa where we are not reaching the 4 per 100,000 threshold. So now for scenario 3, this is again vaccination and then assuming 2 lifetime screens. Again, not much happening even as early as 2030. Some countries are falling below the 10 per 100,000 in 2045. Here's what we look like in 2060. And then most countries are in the blue zone by 2075. So under 10 per 100,000. Here we're looking at 2080, 2090. And then by, again, the end of the century, we see most countries have reached the 4 per 100,000 threshold. And then this is occurring kind of between years 2067 and 2113 at the 4 per 100,000 threshold, and then as early as 2051 at the 10 per 100,000 threshold. Now, what I've showed you so far has been focused on the low and lower middle income countries. We also did an analysis. This is just going to be showing results from one model where we looked at elimination, the potential for elimination in the United States. We know that there has been relatively high coverage of screening, also reasonable coverage of vaccination. And so we wanted to juxtapose the findings from a high income country to those of what you just saw. So I'm going to just orient you to this graph. This is dotted line is showing you the 4 per 100,000 threshold. We also in the United States had considered a lower threshold of 1 per 100,000. This first black line represents our status quo, screening and vaccination. So this is without doing anything, without scaling up either vaccination or screening. And we see that even with the status quo, we do reach elimination of 4 per 100,000 by year 2038. Okay. What happens if we add vaccination scale up? Well, this orange line represents the scenario where vaccination is scaled to 90% coverage. This is for girls only. And we see that the added benefit, right? The line does not change that much from the black status quo line. And that's because vaccination has already been in place in the US with reasonable coverage up to 60, 70% for girls. So increasing coverage to 90% actually doesn't provide us much more benefit in the context of existing herd immunity. Now, this green line represents screening scale up to 90%. And this is assuming 3 yearly cytology-based screening, which has been standard of care in the United States. And here we see that elimination at 4 per 100,000 occurs much earlier in year 2030. And this scenario even reaches down to the threshold of less than 1 per 100,000 in year 2064. In summary, what strategies lead to elimination when we're talking about a 4 per 100,000 threshold? In the low and lower middle income countries globally, 90% of girls only vaccination with 1-time or 2-time screening coverage is required to eliminate cervical cancer in many countries. In the PAHO region, for the low and lower middle income countries, 90% of girls only vaccination and 1-time screening coverage is required. And then in a high income country such as the United States, elimination can be achieved by the status quo, but is expedited by increased screening coverage. And this is just to note that the 2030 WHO targets of the 90% vaccine uptake, 70% screening coverage, and 90% treatment access are very much on this path to cervical cancer elimination. These were embedded in our analyses. When does elimination occur? Across all low middle income countries between years 2060 and 2090. The low and lower middle income countries in PAHO are occurring between 2075 and 2080. And in a high income country such as the US, as early as 2030 out to 2038. So with that, I will turn it back over to our next speaker.
Great. Thank you very much, Jane, for this excellent presentation showing that vaccination together with screening at least twice in a lifetime will reach us to elimination in the U.S., certainly by 2030, and in the other PAHO countries in the next 50 years, and worldwide at least in the next 100 years. So again, this elimination target is feasible, backed by the data. So thank you again, Jane. And we know that government health policies and services and programs are really at the core of cervical cancer elimination. And so to illustrate the government commitments in our region, we have a panel of representatives from selected countries that will provide us with their commentaries. And I'd first like to invite our colleagues from Brazil, Dr. Antonio Braga, who's the Director in Primary Care of the Ministry of Health, together with Dr. Ana Cristina Pino, who's the Director of the Brazil National Cancer Institute, to provide their remarks. Over to you.
Braga, I guess you're the first one. Braga? Hello?
He must have gone. Adelante, Ana Cristina, por favor.
Él está on mute.
Ativa o microfone.
Please activate your mic.
Small introduction. Yeah.
Vocês me ouvem?
Can you hear me now?
Olá, me desculpem, meu nome é Antônio.
I'm sorry, my name is Antonio Braga. I'm the director of the Program and Strategic Actions of the Ministry of Health in Brazil, and I'm representing Minister Eduardo Pazuello, part of the Bolsonaro administration. And I'd like to say that the Brazilian government is working with WHO, and we are participating in the eradication of this kind of cancer. I'm a gynecologist, an obstetrician, and I know this is a terrible kind of cancer that affects the most vulnerable women in our country. And for us in the government, we cannot understand how we have mortality rates for this cancer and at this level. And we have seen a drop in cities, but the numbers have been stable in the last 30 years. We have public free vaccination in Brazil, but we cannot reach all the girls. We have trouble with screening in such a big country such as Brazil. We are working with our institute, especially with Dr. Ana Cristina and her institute, and we are studying how to implement the WHO strategies so that we can eradicate this problem among Brazilian women. I am not worried that this might take some time because we need to work in the long term. As with certain trees, sometimes we have to wait up to 80 years in order to get fruit. So the best gift we can give to the future people is to start eliminating so that future generations can benefit from these actions that the Brazilian government has been carrying out, working with PAHO and the WHO so that we can eliminate this kind of cancer among Brazilian women. I thank you on behalf of my minister and president.
I'll list our main achievements and challenges according to each goal of WHO. So concerning goal number 1, the coverage of HPV vaccination, main achievements were the introduction, as Braga mentioned, of HPV vaccine, the quadrivalent, at the National Public Health System in Brazil called SUS in 2014 for girls and boys. And another one is the implementation of the individual vaccination registry, which is called CIS-PNI, for the monitoring of doses given and girls assisted. So main challenges are still vaccination scale up. Our current annual coverage, according to 2019 data, is 73.1% first dose and 47.4% second dose. Another challenge is the inclusion of schools as vaccination sites following international recommendations for teenagers vaccination. Go to the coverage with HPV DNA testing in women aged 35 to 45 years. So in Brazil, the Ministry of Health's recommendation is pap smear-based screening. So in this regard, our main achievements were sampling at primary care level all over the country, the evidence-based and updated guidelines on screening, improvements in the information system called SISCAM that monitors exams and women as a follow-up, and the implementation of a quality program for cytopathology labs at the National Health System in 2013, which is called Qualicito. Challenges are still the high percentage. Around 9.7% of women 35 to 45 years never tested. And in the North region, which is the worst scenario in Brazil, it gets up to 12.8% of women never tested. Regional inequities, of course, like socioeconomical and and also accessibility. Expansion of this system called SISCAN to the whole country, but we still need to make improvements in the web service, which is necessary. Implementation of organized population-based screening, and most importantly, cost-effective evaluation of HPV DNA testing as standard for screening. Currently, Brazil is a participating center at a project called Marco Project in cooperation with NCI, Trimble knows that very well, and Fiocruz, that aims to compare effectiveness, efficiency, and economical feasibility of new screening strategies. And last but not least, the third goal, which is treatment coverage, including palliative care. Main achievements were guidelines for see and treat approaches using a native visual inspection and excision of the cervical transformation zone, monitoring of the time frame between diagnosis and first treatment by a tool called PAHO, Oncology Panel, Painel Oncologia, of all cancers diagnosed and treated at the public national health system, which is available since 2018. And the reduction in mortality in all state capitals, as Braga mentioned, along the last decades. But many are the challenges still, like structuring of services for the diagnosis and immediate treatment of precancer lesions, like colposcopy, biopsy, and excision. Expansion of treatment offered, especially surgery and radiation therapy, and through a great national plan called the Expansion Plan in Radiation Therapy, which will deliver 100 solutions, radiotherapy solutions all over the country, and the reduction of the time frame between diagnosis and the first treatment. So 23% of cases are still above 60 days. So this is a real challenge for us. So thank you.
Thank you very much, Dr. Pino and Dr. Braga, for commenting on the efforts being made in Brazil to expand access and coverage for vaccination screening and treatment. Thank you. Now over to Costa Rica, and I invite Dr. Roberto Arroba, who's the head of the National Immunization Program in Costa Rica.
Hola, buenos días, Dr. Luciani.
Good morning, Dr. Luciani. Thank you so much for your invitation. Thank you for inviting me to the regional launching of this important program for the cervical cancer elimination. We, in our country, are very optimistic about reaching this regional target of control of cervical cancer. And I think the immunization program is a universal one. Both the public and the private sector services give access to vaccinations with good vaccination coverages. Last year, we started the universal vaccination against the HPV, and we were able to vaccinate about 98% of our target population with the first doses, 95% with the second one. We know this is a big challenge. To maintain this coverage, this vaccination coverage is a big challenge. But in our country, there is a culture of vaccination. And in addition to that, we have laws. And these laws helps in cases where parents do not want their daughters to be vaccinated. So we have to stress the right that these young girls have to be vaccinated to avoid cancer later on in life. And then screening has been very important in our country too. We have social security services, and they cover 95% of the population. We have high coverages of screening. Finally, here in my country, we have had very important research experiences, especially our research on papilloma. You remember that we spearheaded the efforts for this research and other studies in order to make a reality of our dream. Initially, we thought of 2 dosages, but we're aiming to the 1-dose vaccine. So this will allow us to have vaccination for all children. We believe that this is a challenge, a great challenge for the countries. However, we're optimistic that we will be able to eliminate this disease. Thank you so much.
Thank you very much, Dr. Aroba, for sharing your optimism about cervical cancer elimination in Costa Rica, and congratulations on those high vaccination coverage rates. So we're going to move over to the Caribbean now and to Suriname, and I invite my colleague, Dr. Els Dans from the Ministry of Health, medical oncologist, to provide her perspectives.
Thank you, Silvana, and thank you very much for the invitation to speak here today. So in Suriname, there are many problems and challenges. Of course, a high incidence rate, still 22 per 100,000 females. The higher mortality rate pointing to still a high fatality rate, which of course is a similar situation in many countries in the region. And there's no decline in the last 30 years. This is really, I think, very embarrassing for my country. And this has everything to do with the late presentation because of the absence of a national screening program. And the other problem is we have no cancer registry, so we have no reliable data. We do have, I'm starting with telling the positive things, we do have HPV vaccination. I'm very glad with that. But the problem is there's no monitoring and evaluation programs, but actually we have no reliable data on the coverage. And we think it may be 50 or lower percentage. Treatment was improved. We had radiotherapy since 2012. I think this was really a major step forward for the treatment of cervical cancer in my country. But we still have dropouts, more than 10%. And this has much to do with fear and I think lack of support. So those are the challenges and the problems, just to name a few of them. So I'm going over to the opportunities. I think there are very important good things happening in my country. One of the most important things is the governmental commitment. This did not translate yet in a nice budget, I must admit that, but they did adapt the National Cancer Control Program for the coming 10 years, which of course includes cervical cancer elimination. And they already did, this is a new government this year, and they did include cervical cancer screening program for the coming year in their policy program. And of course, there's still the school-based HPV vaccination, and they still pay for it. So those are very important things, I think. The other good thing is we have a very committed oncology workforce. All cervical cancers are being discussed in a multidisciplinary team setting, and there's a dedicated treatment center, and this really improved treatment and decreased the waiting times. I just was hearing Dr. Aroba talking about. So in addition to that, this oncology workforce is busy with setting up a hospital-based registry as a first step towards a population-based registry. Third, but certainly not in the least, there's an increase in the community engagement. I think this is very important. We just had 2 projects that were very successful. One was a pilot rollout program, screening program, relating to the very many different ethnic groups in my country. And what they did, they used a community-based approach. They tailored it to the local situation, and they included a survey on barriers. And this gave us a lot of information on how to develop and implement a successful national screening program. And the other thing that was very successful was being done in the interior among the indigenous and the Maroon people. It was a project on increasing knowledge and awareness, and it immediately increased coverage in screening. So I think taken together in my country, there are many problems and we don't have a structure yet, but I think we do have the necessary building blocks to get a structural cervical cancer elimination program. And also, I must say thanks to the support of PAHO. Thank you.
Thank you very much, Dr. Dans. And it's encouraging to see these important progresses being made in Suriname to have a structured program for cervical cancer. And thank you for highlighting the importance of engaging with women in communities and raising awareness and understanding the barriers. So over to the USA now, and I'd like to invite Dr. Ted Trimble, who's a researcher at the US Cancer Institute, which also serves as the WHO Collaborating Center for Cancer. Over to you, Dr.
Thank you, Silvana. We're excited by the opportunity of this global initiative because many of the interventions are based on research that we help support, whether it's through HPV vaccines or HPV diagnostics and triage, self-collection, new treatment algorithms are based on research that we helped to build. Just as an example, we are also working with the Gates Foundation in a study in partnership with investigators in Costa Rica comparing 1 versus 2 doses of HPV vaccines. We've also set up a new network involving sites in the Caribbean and Latin America to look at the intersection of HIV infection and HPV infection. My own institute, the National Cancer Institute, our sister institutes, the Centers for Disease Control and Prevention, are available to help with other PAHO member states in terms of technical assistance for cervical cancer prevention and control. We are also want to highlight some of the modeling that Jane Kim and her colleagues did looking at cancer treatment. I know Jane didn't have time to present it today, but there's good evidence that if we can improve access to treatment and improve quality of treatment, we can reduce the mortality of from cervical cancer by 2030, consistent with the goals of reducing NCD mortality of 30% by 2030. I also want to emphasize the importance of making sure that we have effective symptom management, survivorship, palliative care, all of which are interventions we know how to deliver, and we need to make sure that they happen routinely. Finally, I want to say we're looking forward to working with Silvana and her colleagues at PAHO to strengthen collaborations between PAHO member states, with WHO, with the International Atomic Energy Agency, IARC, and other UN agencies. Thank you.
Thank you very much, Dr. Trimble, and thank you for your ongoing support to this regional elimination initiative. And we know that eliminating cervical cancer will really require a multidisciplinary and multi-stakeholder effort. So to illustrate the breadth and depth of commitment that we have in the Americas regional civil society groups, we have an outstanding group of speakers in our next panel who will provide some remarks. And we'll start first with the Brazil Society of Immunization, and I invite Dr. Renato Kafuri.
Olá, Silvana, prazer estar aqui com todos, uma honra.
Hello, Silvana, it's a pleasure to be here with you. It's an honor to discuss such a relevant topic in the context of what I consider to be a very daring goal to reach 90% of vaccine coverage, 70% of screening coverage, and 90% coverage for treatment for HPV. But I believe that only by being daring with very specific goals such as these, that we will indeed be able to define goals such as the elimination of cervical cancer. In the 3 pillars, primary prevention through vaccine, diagnostics, and treatment, I believe that primary level prevention has a key role because it can allow for a drastic reduction in the treatment and prevention outcomes, as has been shown here today. However, the challenges in vaccinating teenagers is huge. We have faced huge challenges in guiding and taking these teenagers to vaccination centers, not only in Brazil, but worldwide. I believe that allowing these immunization programs to become part of other teenage programs, such as drug prevention, teenage pregnancy, education in general, can be a good path, as well as school-based vaccinations. I do not know any country in the world that was successful outside of a school-based program. So I believe that this partnership, this closeness between the Ministry of Health and the Ministry of Education would be essential for any prevention program to be successful. Otherwise, we will probably not progress in teenage immunization without the school support. In Brazil, the Brazilian Society of Immunization, which I represent, along with other organizations such as the Brazilian Society of Pediatrics, UNICEF, and the Pan American Health Organization, have been supporting the ministry in reaching vaccine coverage rates, increasing the level of information that the population can access, many times because of compliance reasons, or government itself has a difficult time carrying out certain campaigns to reach a certain level of buy-in and financing for all of those actions. So I believe that the scientific society, fulfilling their goals and responsibilities of training not only medical professionals, but educating the population, can catalyze these actions, creating a connection between community, government, and making information easier to flow so that knowledge can be disseminated, especially in this world of social media and so many fake news, so that we can be successful. Communication is an essential ingredient for us to reach this goal. And we'll only be able to communicate our intentions, our efforts, and how worthy vaccines are if we do so in a manner that reaches our teenagers. Communication is everything. Thank you very much for this opportunity to be with you. It's always a pleasure to cooperate on my behalf and on behalf of the Brazil Society of Immunization.
Importance of working with education for school-based HPV vaccination. We turn now to Basic Health International, an NGO and official relations with PAHO, and to Dr. Mauricio Massa for some words.
Muchas gracias, Silvana.
Thank you so much, Silvana. Today is a very special day in the launching of this cervical cancer elimination initiative. In the face of adversity, we have to think of opportunities, and the COVID-19 pandemic has led the countries, not only locally, but around the world, to increase their capabilities to eliminate this type of cancer. And in the face of the pandemic, this is very important. We have molecular tests to detect this. I'm sorry, the English interpreter is not hearing the speaker well. The words are being cut off. We will try to do our best. We will try to improve our screening and surveillance programs to be able to control the population that is being covered with these exams. We have several important documents that are being published. One of them is the increase in the number of tests for the detection of HPV, and then this will all lead to the prevention of uterine cancer. Little by little, we are initiating the process of introduction of molecular tests. Within the national budget, we must include the test for HPV. And we have started HPV vaccination.
Dr. Mazza, we've lost the connection. I know that you're based in El Salvador and there were some problems with weather, and so the internet has been affected.
Pero es algo que es posible y está en nuestras manos. Esperamos que todos los
países what we can to make sure that we make these countries of the region aware of the importance of these targets. Gracias.
Countries to introduce HPV testing as part of cervical cancer screening. We turn now to the Healthy Caribbean Coalition, another NGO that's in official relations with PAHO, and over to Heather Mia Usher, based in Belize, for some remarks.
Thank you, Silvana, for the invitation. The Healthy Caribbean Coalition applauds the WHO on the launch of this historical global strategy, which is specifically geared towards the ambitious but achievable goals of eliminating cervical cancer. This is a collective goal that together we'll be able to achieve in the Caribbean region. With the support of our partners like PAHO, WHO, CARFA, and regional member cancer societies of the HCC. The HCC and the Belize Cancer Society continues to partner as we have recognized cervical cancer in the region as an immediate threat to the health and the livelihood of our nations, especially our girls and our women. The HCC has successfully partnered with various international organizations and national cancer societies to advance cervical cancer prevention in the Caribbean through advocacy and action aimed at building the capacity of civil society to educate, to vaccinate, to screen, to diagnose, and to treat our Caribbean girls and women. Since 2013, the HCC and the Australian Direct Aid Program has supported my organization, the Belize Cancer Society, and the Belize Ministry of Health and the Ministry of Education in the delivery of education and screening for thousands of Indigenous and indigent Belizean women in my country. We've used multi-ethnicity approaches as well as for the joint introduction of our national HPV vaccination program. And we included associated education campaign to support our teachers, faith-based organizations, and to gain parents' approval for this vaccination program. Notwithstanding all the efforts that we have to put into resource mobilization, the work of the HCC has been recognized globally by the WHO Global Coordinating Mechanism on NCDs in 2015 and by the NCD Alliance in 2017, when the HCC received the Chargé Civil Society Award of Excellence in Access to Care. Today, the HCC released an open letter to our heads of CARICOM, calling on them to prioritize cervical cancer elimination in their national health responses and re-emphasizing the HCC's commitment to support this agenda. We have long believed that the goal of eradicating cervical cancer, although no small feat, especially in resource-limited settings such as ours in the Caribbean, was achievable. With the launch of this global strategy, our goal is within reach now. There is now a strategy to drive multi-sectoral and stakeholder approaches, member state-led actions towards the attainment of this 90-70-90 target. We take this opportunity to thank the WHO and PAHO for all they have done, and we continue to call on our Caribbean governments and regional institutions, such as CARFA and CARICOM, with the support of the WHO and PAHO, to continue to invest in civil society partnerships and increase and intensify our collective efforts so that together we may reach these ambitious targets and ensure that no Caribbean woman dies unnecessarily of this preventable disease. We once again applaud the WHO and we thank you for this opportunity.
Thank you very much, Heather, for reminding us of the importance of civil society partnerships with governments. And now we're going to move to the Professional Association, the International Federation of Cervical Pathology and Colposcopy, to Dr. Carlos Perez. Dr. Perez.
Muy buenos días para todos.
Good morning, everybody. In 1972, my federation was established in Mar del Plata with the objective of increasing applied and basic in research to pathology and cervical pathology and colposcopy, and to the evaluation of different therapeutic procedures applicable to cervical cancer and how we can prevent this disease. We have great developments about the vaccine. In the short term, we know that secondary prevention is an essential element in the control of this disease. Our federation is an institution that is devoted to give adequate responses to the great challenges that we have today in this field. We joined the campaign of the elimination of cervical cancer, and we have established distance education courses since 2014. This has been translated into 6 languages around the world so that we can control the quality of cervical pathology and colposcopy. And also we have started courses for specialists, for general doctors, for medical students, for the promotion of the control of this cancer, to promote the control measures for this cancer. The last conference that we had was in Rio de Janeiro in 2011. Next year, we will have another conference to establish a new classification that together with another doctor, we are working on. And then this will lead to a strategy that will be studied by a very special group with Dr. Silvio Tassi. I will be heading so that we have new guidelines for the elimination of this type of cancer. We are quite sure that our work will contribute with a grain of sand to this enormous field of control of cervical cancer.
Together to build capacity for cervical pathology and colposcopy. Over now to the Medical Oncology Association of Latin America and the Caribbean and Dr. Eduardo Cazap.
Buenas tardes a todos. Muchas gracias, Silvana, por esta invitación.
Thank you so much. Thank you, Silvana, for your invitation. We all recognize cancer as a chronic disease. And that is the way it is defined in public policies. Well, this is a paradigm because this cervical cancer is something that already has a vaccine and that we could improve the situation around the world. So what we have to do is comprehensive cancer control through research, primary prevention, screening, diagnosis, and so forth. In that sense, our organization is working with 4 combined strategies. One is targeting the general population, and we have a group of oncologists, Latin American oncologists, working against this type of cancer. We are working with IARC and PAHO, and that was one of our strategies. The other strategy is that we do not have a general guideline for the countries, but only through the national budgets and guidelines and so forth. So we are working on a coalition to have general guidelines as regional guidelines to be able to plan for the strategies. And the other project that will lead to a regional effort will be our work with Harvard University, the Institute for Health in the Americas, and that is a comprehensive initiative for cancer control in Latin America to see how we can improve these efforts in our countries. You will find this in our webpage. The last avenue has to do with the important field of primary and secondary prevention. And on this, we are working with the coalition of Seracom and RIN, working together with us. And we believe that this is a 4th tool that will allow Latin America in a coordinated and strategic way to control cervical cancer.
Thank you, Dr. Cazap, for the support, continuing support with RINC, FLACOM, and all the partners that you bring with you to the region. And we look forward to continuing working together. Now we move to Dr. Mila Salcedo from the MD Anderson Cancer Center, who's also with the Santa Casa de Misericordia de Porto Alegre and Universidad Federal de Ciencias, for some words of support. Over to you, Mila.
Thank you so much, Silvana, for the invite and for the opportunity. Eu vou falar pouco então sobre o MD Anderson Cancer Center, que é uma instituição
I will be talking about the MD Anderson Cancer Center, which is a cooperating agency that works with PAHO and also with the WHO. We have really improved the treatment of this disease in the whole world. We have been working with research, education, advocacy, and clinical services. Our team prepared a program with collaborators all over the world, and it's a very comprehensive program training professionals working in low-income and middle-income countries. It was developed for the Americas and for the world. We have been carrying out research with partners in especially Brazil and El Salvador with Rebecca Richards-Cartman, and we have been developing new technologies in order to prevent cervical cancer, especially in areas with low resources. With other institutions in Brazil, we have been working against this cancer in Africa, especially in Mozambique. We offer training in colposcopy, and we have a multidisciplinary team in order to assist doctors and nurses locally. The doctors in Brazil and doctors from MD Anderson Cancer Center have been training doctors in Mozambique in order to diagnose and treat women with gynecological cancer. The first 3 doctors in Mozambique have just been through the training, and now women in the country have access to specialists in the country. We also support training in Latin America in order to have sustainable programs. We have video conferences to offer mentorship and support to health professionals. We have a network of more than 14 countries in Latin America, and we also have a program to eliminate cervical cancer in the Americas, working with the Cancer Institute in the United States and with PAHO. MD Anderson works with society and partners in order to eliminate this cancer. And we're very proud of our work with our partners and with PAHO. And it is an honor to be part of this very important initiative, this very important day. And we hope to be able to bring our programs to other countries and regions.
Commitment and support and partnership to build capacity for diagnosis and treatment of both pre-invasive and invasive cancer in our region and in the world. And we go now to Rotary. Many of you are familiar with Rotary as a community agency and leading the global polio elimination effort, and we're proud to have Rotary as a partner with us in this elimination effort for cervical cancer. Over to you, Carl Diekman.
Thank you, Savannah. And greetings from the Health Education and Wellness Rotary Action Group, often referred to as HURAG. I'm Carl Diekman, a member of the Rotary Club of Woodland, California, USA, and a director for HURAG, where I primarily focus my efforts on cervical cancer prevention. HURAG began to encourage Rotarian participation in cervical cancer prevention efforts after our participation at the Investing in Cervical Cancer Prevention 2015-20 conference in London on November 4th, 2015. Today, I am honored to represent the hundreds of Rotarians from around the world who are members of HURAG and focus their effort on cervical cancer prevention. I want to tell you briefly about the projects that Rotarians and their partners engage in. Rotary projects typically involve a host Rotary club in the country where the project occurs and a Rotary club or clubs from different countries or a different country. Projects range from $30,000 to hundreds of thousands of dollars, with most funding coming from Rotarians and the Rotary Foundation. Projects are always built around needs as established by the community where the project occurs and where commitments have been made to sustain the effort once the project partners have completed their work. We typically support training programs, equipment purchases, awareness campaigns, and much more. In recent years, Rotarians have established more than 40 projects that have focused on one or more aspect of cervical cancer prevention, treatment, or care for women who have cervical cancer. I'd like to mention 2 examples. In Ecuador, Rotarians from Alberta, Canada, and Ecuador are transferring knowledge by training local clinicians in VIA and cryotherapy in conjunction with a clinical project to serve women who otherwise could not receive examinations. In Nicaragua, Rotarians from California and Nicaragua provided a VIA and treatment training program that certified clinicians in VIA, cryotherapy, and LEAP at 5 clinics in Leon and the Bluefields region. After a year-long training program and hundreds of examinations, 5 clinics were outfitted with the necessary equipment to continue the work. Today, Rotarians are exploring opportunities to add new technologies as they continue to expand their projects. The adoption of the cervical cancer elimination strategy offers Rotarians a guide for future projects, and we are very grateful for the leadership of the Pan American Health Organization and the World Health Organization for adopting and promoting it. Thank you.
Thank you very much, Carl. And to all of our civil society partners, I'm really grateful for all the support we have. We have many, many more professional associations and NGO partners who didn't have time or space on our panel. So we've put together a little video of all the others and that we'll share at the end of this session. But right now, I'd like to turn over to my colleague, Dr. Lucia de Oliveira, who is the regional advisor on new vaccines and the immunization unit at PAHO, to provide some final concluding remarks. Over to you, Lucia.
Thank you, Silvana. I'm going to take advantage. I'm going to talk in my original language, Portuguese. It's not always that you have this opportunity. Muito obrigada, Silvana.
Thank you very much, Silvana. It's a great privilege for our immunization unit to be able to close this session in this important day that celebrates the elimination of cervical cancer. We are very encouraged to do this work because we could hear the countries, their proposals, how they have been facing the challenges that are many, as well as the work done by civil society, which is also very important. And it's very important that the ministries of health work with civil society so that we can reach the targets that we are trying to reach. I'll repeat something because I think that it is something we should always have in mind. We need 90% of coverage of vaccines, 70% of screening, and 90% of treatment. These numbers need to be in our minds because with these numbers, we can reach the target. And this is so important for public health. And this is what we all want. I would like to say that it was very important to see that we had more than 400 participants, attendees here today. This means more than 400 people who are interested and who want to reach this target. So thank you very much and congratulations.
Yeah, and thank you to all our speakers, our partners, our participants, and especially our interpreters to allow us to transmit this in 3 languages. And we look forward to working together towards cervical cancer elimination in the Americas. And we'll end now with the video of all the additional supporting organizations, institutions, and individuals who'll be working with us as we go forward. So over to the last video, and I wish you all a great day after the video. Thank you.
Desde la Agencia Internacional para Investigación en Cáncer en Lyon,
from the National Agency of Research of Cancer in Lyon, France, I had the privilege of directing a series of epidemiological studies in 40 countries throughout the world, including most of the Latin American countries. These studies showed that the human papillomavirus is the main cause of cervical cancer. This discovery made it possible for us to come up with a prophylactic vaccine that protects against virus infection and can eliminate from 70 to 90% of the virus, of the cancers rather associated with this virus. And an HPV test that allows the detection of precancerous cervical cancer lesions with great precision. Now, what's tragic is that despite these 2 weapons having been available for over 20 years, cervical cancer continues to be a major public health problem.
Brazil is
a continental country with different realities that reflects the diversity in Latin America. Unfortunately, cervical cancer screening coverage is low in our country. Increasing HPV vaccine coverage is a challenge. The COVID-19 pandemic makes this challenge even greater. We have to change this sad reality. We are committed to all women with cervical cancer offering timely and accurate multidisciplinary treatment, and ensuring full support to these women and their families in all stages of treatment and follow-up. This is our commitment, not only from health professionals, but from all of society.
Women
with HIV have a high risk of cervical cancer. We are a population that is very vulnerable. And so this owing to stigma and discrimination and to gender-based violence as well.
For the implementation of HPV vaccination, along with screening and treatment of pre-invasive and invasive lesions, may be the last meaningful intervention that will eliminate and eradicate cervical cancer. But we have to do this together as a whole of society effort in order to save our boys and girls once and for all.
El Instituto Nacional de Cancerología es asesor del Ministerio de Salud y
The
Protección.
Cancerology Institute is an advisor to the Ministry of Health and Social Protection, and that we have a very safe, it's very important that we have a safe vaccine available, and we can help people to understand that we do have such a vaccine, which should be applied to girls, and we should promote screening and early protection in the different regions according to the resources. And we want the majority of women in the country to have the certainty that this disease will be eliminated. We have a strategy in this country that is to vaccinate to girls in schools. This has enabled us to achieve high vaccination coverage, such is the case that we started universal vaccination against papilloma last year. And we were able to obtain coverage of 98% in the first dose and 95% in the second. This is very important to us because it ensures that we have high coverage and that what we want is to maintain that for about 20 years so that when these girls are adults, they are protected and we can then and thereby eliminate cervical cancer.
We need to do it through vaccination, we need to do it through screening and early detection. These are things that are accessible and available all over the world, and if we work together as one, it's time to end cervical cancer once and for all.
Cervical cancer can be a curable cancer, yet millions of women around the world who contract cervical cancer are dying with pain because of no access to the appropriate treatment. But we know that with prevention, with screening, with access to treatment, these women can be cured and be back to their family, to their kids, to the society, and make a contribution to the world. Yes, it is time to end cervical cancer.
When we think about cervical cancer elimination, we need to think about it in a comprehensive way that includes early detection, vaccination, and also treatment. We need to continue to invest in radiotherapy on a global scale to treat this devastating disease and cure women so that they can return to their productive lives. It's time to end cervical cancer.
It is indeed astounding to be able to talk about meeting the 70-90 targets and saving lives of thousands of women worldwide.
Las mujeres relegamos a hacernos un PAP por las múltiples actividades de las que
women relegate doing a PAP smeared to the multiple activities we take care of, work, taking care of the house, children, family, and so forth. In addition to a gynecological exam, it's not always pleasant, but now there's a new highly effective method, the HPV test, which gives us women the possibility to take the test ourselves at home, even at a health center. This is revolutionary because it gives women autonomy to prevent cervical cancer. And it's a small gesture with a huge impact in the lives of women.
I can contribute to the elimination of cervical cancer by increasing access to preventive measures like the HPV vaccine, screening and early detection services in my community. And I've been working hard to ensure access, but people still have significant barriers to care due to lack of health insurance, structural barriers, and intrinsic racism that's built into our healthcare system and institutions and in our communities. So we must fight to overcome these barriers and eliminate cervical cancer once and for all.
En la región centroamericana se ha realizado mucho en el tema de cáncer cervicouterino.
Much has been done in Central America from the studies of natural history of the disease carried out in Costa Rica, in Panama. Panama is one of the first countries in the world that introduced the human papilloma virus vaccine. In El Salvador, there's a low-cost biomolecular testing program that was introduced to have a program of screening and treating with cryotherapy. In Guatemala, a self-test was included among the guidelines to increase screening coverage. And in Honduras, much has been learned from thermal ablation as an alternative treatment. These are basic tools that we need in order to eliminate this disease from our region. We need to work together, join knowledge to make this possible. Necesitamos asegurarnos de que cada paciente elegible reciba la vacuna contra el virus que causa el cáncer de cuello uterino, el VPH. También tenemos que asegurarnos de que nuestros pacientes sean examinados y tratados por cualquier lesión precancerosa. The challenge in implementing this elimination strategy is important because the COVID-19 pandemic has put many prevention programs at risk. Now the whole world aspires eagerly and eagerly awaits a vaccine against COVID-19, which is why we need to make every effort to use a HPV vaccine, which is a safe, effective vaccine to eliminate cervical cancer.
Together, we will change the sad reality of cervical cancer in the world.
So once again, thank you everyone for joining us in this historic momentum to launch global elimination for cervical cancer. And that concludes our session. Thank you. Have a great day.